Thank you very much. It's a pleasure to sort of update everybody on what's been going on in curriculum renewal over the last many years. There's been a big change at UBC that was this year marked the rollout of the quote-unquote new curriculum with the graduates in the class of 2019 being the first who will graduate having gone through our new curriculum. I'm not of use to anyone in disclosures. So I'd like to talk about the rationale why UBC went through what was the need for curriculum renewal, to outline sort of what has currently been done with curriculum renewal and the progress that we're making to date. It is a work in progress. We're far from finished. But this is just an update on what's been going on. I want to review how we've been able to create opportunities to get urology into the curriculum and how we plan to have students exposed to the vast amount of material that a lot of them will use if they're general practitioners from a urologic point of view. But the main thing I want to do today is sort of get feedback from you on the direction, ideas that you may have, and have you sign your name up to help contribute to this. I know some of you are looking for the pillows, and for this isn't that exciting a topic. Others of you are scrambling to remember your Wi-Fi password. But I'm hoping that at the end of this, you'll at least have found it a little bit interesting. So as we all know, UBC is the only medical school in our province, which with that comes a great responsibility to train physicians that will be useful to this province. After the expansion in 2004, our medical school is now up to 288 students, spread over 4 geographic sites. The distributed medical program really changes the way that we need to deliver education. There's students simultaneously in the North, the Island, the Southern, and the Fraser program all being learners. And so we need to create a cohesive learning for all of the sites and be able to deliver it geographically. There's over 80 clinical sites now throughout the province, and there's several thousand faculty, and so with that brings unique challenges. But why now? Why curriculum renewal? Why is it necessary? And it all stems from accreditation of our university back in 2008 and 2009. In 2008, the undergraduate medical education underwent accreditation. And in 2009, we had an external review, and both of those were after the initial expansion of the medical school. Both of them noted in their accreditation reports that there was need for curriculum renewal and gave the university what some call a provisional or others call an in-progress acceptance, saying that it's imperative that the curriculum be looked at. Because at that time, the blueprint for the curriculum was from 1994. A lot's happened since, sorry, it was 1997, and, a lot's happened since 1997. We have Facebook, and we have YouTube, and now we have Justin Trudeau. And when you look at it in the education realm, there's been so much advancement in scientific knowledge, there's been so much advancement in technology, and then with our distributed delivery, our curriculum and the blueprint, the delivery we were utilizing is ancient. So the dean in 2009, printed in 2010, had a task force on curriculum renewal that was run by the chess education department here, looked at curriculum renewal and what was necessary at UBC, and they wanted to use evidence-based education as our mode of delivery. And they base it upon large recommendations from national bodies. One of the largest ones is the Association of Faculties of Medicine in Canada, that in 2010 published 10 evidence-based recommendations on how medical education can best be delivered to be useful to our population. They looked at 10 different domains of education, and they said there should be a focus on leadership, there should be a focus on community needs, that the admission process needed review from just taking the top marks to taking the overall well-rounded students. They discussed the need to focus on the scientific basis of medicine and areas of prevention and public health. Some interesting ideas about the hidden curriculum, that curriculum that isn't directly taught, but it is observed, the attitudes, the observations that students pick up, and then focus on different learning contexts. Get away from the didactic lecture exam, and to focus as well on inter and interprofessionalism, competency-based education, and to value a generalist approach, especially in Canada where we suffer from lack of primary care physicians. So those 10 recommendations were taken forth, and a similar report was put out by the Carnegie Foundation of Education that said, okay, we need to focus on standardizing learning outcomes, integrate different specialties, not be within our silos, to promote lifelong learning and access to information, and then to focus on how a doctor not only obtains information, but also forms their professional identity, how they're going to go about practice, and how they want to make a meaningful difference. So the Dean's Taskforce on Curriculum Renewal came forth with their 126-page report that came with 8 recommendations for whoever was going to be in charge of curriculum renewal, saying that these would be the focuses of UBC's curriculum renewal, is focusing on social responsibility and accountability, matching the competency-based approach to education and curriculum that mirrors the Royal College, to look at student assessment and make sure that it's aligned with curriculum and valuable as a learning, not just a learning tool, and then look at ways that people learn, providing flexibility in learning style. We now talk about the 70-30 split. 70% of the time you're being taught, 30% of the time is up to you to take that time to synthesize the information, put it into context, and self-directed learning. They also recommend that we focus on scholarship and integration of the curriculum, and look at continuity of care, continuity of curriculum, continuity of faculty, and at the end of the day, also focus on the healthcare system, making sure that we have a safe, quality care system, and look at the way that technology can be utilized to assist with that. So UBC, when we started undertaking curriculum renewal, had 3 goals that they stated: that they wanted to increase the flexibility of learners, that they wanted to provide opportunities for different faculties to work together and learn from each other, and in the end, the goal is to move towards a competency-based integrated spiral curriculum. Now, this goal is a bit of a mouthful. What exactly did they mean by that? And it took me a while to wrap my head around that last statement of theirs. What does it mean to be competency-based? We talk about it in residency now, but in essence, they're looking at taking it from simply being able to regurgitate knowledge to taking it to an observable ability. At the end of the day, what are these goals that we have for students to be able to do, to be able to perform? And so the exit competencies have been formulated now for medical education. And so what is the competency? It's an observable ability of a physician to perform a task that is part of a physician's work. So it's not just the knowledge, but it's the ability to synthesize that knowledge, make a differential diagnosis, make a decision on a plan, justify that plan, and then communicate that to your patient. And at the end of the day, the assessment is going to be based upon the student's ability to demonstrate these exit competencies. Now, the competencies in medical undergraduate education have mirrored those that were in CADMED's last edition, which look at domains of medical expert, communicator, collaborator, manager, health advocate, and scholar. CANMED's postgraduate has since come out with their new recommendations that are not so siloed, and they're more based upon the professional identity, but undergraduate is still looking at these domains simply from a structure point of view. What is a spiraled integrated curriculum? So previously, we were in a block formation, so anyone who's gone through the UBC curriculum knew that these 4 weeks were cardiology, the next 4 weeks were renal, FRGU, then you did infectious disease, so we were in a block format, and so there wasn't a lot of crossover. You didn't revisit topics. And so the idea of a spiraled curriculum is that really you're taking themes of cases, but you revisit the quote-unquote silos of information multiple times throughout. So it isn't a cardiology block. You will have a patient present with hypertension early on in the curriculum and talk about that aspect of cardiology. And then many weeks later, you'll have a patient case that talks about ischemic heart disease. And so you revisit this topic throughout the curriculum. And it's known from educational learning theory that the more you revisit topics, the more you build from the base up, the greater the understanding you have. So it allows for these connections between the topics, because we all know that when we see a patient, you never just have quote-unquote a urology problem. You have to have it all in their context. Right? So you need to make these connections in order to build your professional identity. Our previous curriculum was built upon problem-based learning, okay? And now the new curriculum is going to a case-based learning. And I didn't quite understand the difference of that, and so I went to the UBC website, and they made it clear here that said it's a longitudinal learning experience used to facilitate developmental and clinical reasoning and decision-making. A CBL session integrates foundational science concepts with, I don't know what that means. So I looked into a little bit further what case-based learning versus PBL is. And so PBL is really presenting the learners with a problem and letting them go out and formulate what they think the learning objectives are, investigate them themselves, take a group discussion on that, and at the end come to some sort of conclusion about what the week was and what you wanted to learn from that week. The role of the facilitator is minimal and passive, and you're not necessarily giving them stated learning objectives. In case-based learning, in essence, it's a guided inquiry. You're giving them a case, but then you're guiding the learning that you want to come out of that. You're providing them with material you want them to prepare before the discussion sessions, as opposed to letting the discussion just flow organically. And the role of the tutor is more active, so you're more guiding the learning. So case-based learning is seen as possibly a more effective or efficient manner of delivering information. One of the the difficulties with problem-based learning, or one of the criticisms of it, is that some students or some learners feel that they can go an entire week and have great discussions, but at the end of the week not learn the material that they feel that they were quote-unquote meant to learn, the objectives of the week. So case-based learning is more focused, gives them learning objectives, and but still is based upon clinical problem solving.
With PBL, a lot of the tutors were non-content experts. Mm-hmm. So does that imply that the case-based learning, you're going to have to hire or find more content specific tutors?
So ideally that would be the case, but it's not practical in the medical school setting. The guided inquiry will be provided mainly based upon making sure that the objectives that the students are discussing are task specific. So if they start discussing something that is not an objective of the case, the tutor will jump in and say, no, the objective is this. They don't necessarily have to know. So if we say the objective is to discuss PSA screening and prostate cancer, and I want you to discuss that, they don't necessarily have to be an expert on that, because it's up to the students to then go and take their pre-reading material and their own research to fill that. So they don't necessarily have to deliver the content themselves, they just have to steer them into the right direction, which is challenging as a tutor. Because it's often easier to just guide with answers as opposed to guide with questions. So here in case-based learning, they discuss providing guiding questions and feedback on answers. So it's imperative that each tutor does have a manual based upon the learning objectives and the expected points of learning.
Are two groups the same size, more or less?
It depends. Yes, in our system they will be. Problem-based learning can be quite variable. They say the optimal size is about 9 students. I know in our PBLs they're up to 15 or 20. But case-based learning is fairly new. I don't know the optimal size. I don't know if anyone does. So, we know that we need to renew the curriculum, but now we get into the work is developing the courses, and so it was a collaboration with all faculties, trying to figure out how we're going to deliver this vast amount of information over 4 years, and who gets what part of the pie. So for course development, what the university has done is set out groups of responsibilities. So there's an assessment side of things and a curriculum development side of things, course development, and they've broken it down into systems and themes in terms of creating the information. And the systems they've defined as a group of organs that work together to maintain homeostasis, and the system doesn't work in isolation, but for the purposes of curriculum, this is the silo that it's been put in. And if we look at the systems, before we were looking at cardiology, FRGU, and infectious disease. So now we've looked at it from a systematic approach: a behavioral system, blood and lymphatic system, nervous system, reproductive system, and we have been placed in the urinary system, which is in essence FRGU. It's all of the systems composed of the organs involved in the formation and release and excretion of urine. So this is, if you want to think of it as departmentally, it's nephrology and urology. And as systems leads, myself and Sanit Singh are co-leads of this urinary system.
What about the important, we're also reproductive?
Yeah, how
exactly.
Sex?
So I am co-lead of reproductive as well.
Sorry?
I'm co-lead of the reproductive system as well. Yeah. I was voluntold. So those are the themes. Those are easy to sort of intellectualize. They also there's also people in charge of clusters and themes, where clusters are sort of similar areas of academic learning, and themes are the skills and knowledge and attitudes domains. And so to discuss those, the clusters are medical science, diagnostic science, and treatment. And Jeff Blair just pulls out his hair that he only gets a little mention in all of the medical school as a theme of surgery. And we fall under that as well.
Just a concept, right?
Just a concept. Just a concept.
Which can?
Complementary and alternative medicine.
Wow, we're right there.
We're right on par.
Right with them.
Yeah.
Is that a spiral? Is that a spiral approach?
Yeah, exactly. So it's, this was quite a controversial.
But where does evidence-based come in that?
So evidence-based.
Right beside surgery? Or?
Well, no, I think that's the entire theme to the curriculum. That's the overlying principle, is that it all needs to be evidence-based. There is no theme that focuses on, I suppose it could be under population health and informatics, possibly, but there's really no theme or cluster of evidence-based. It may fall under scholarship, and I suppose that's where we have it here. But it's interesting to me that it's been clustered sort of down at the bottom of this hierarchy of.
But I thought that the whole curriculum was based upon evidence, and yet you've got a whole section on.
Yeah.
Yeah.
Yes.
Which is that by its nature tends to be
non-evidence based.
Yeah, non-evidence.
Yeah. And that is, yeah.
You could be bashing.
Right.
You could be just bashing.
You mean, yeah. So
present it and say that it's not
perhaps
evidence-based, so don't go after it.
Mm-hmm. I know. I don't know how that's going to fit into the new curriculum. Honestly, it's not. The first year has been laid out in terms of the virtual course book, but the second, third, and fourth have not. And I'm interested in seeing how that's going to be integrated.
Isn't there a huge hole there? I mean, where's the non-surgical medical care? I mean, you see it mentioned.
pharmacotherapy.
Pharmacotherapy, and then so the non-surgical care will fall under the foundational systems information delivery. So, we will talk about pharmacotherapy, and this is simply, as we formulate these weeks, that each system, each cluster, and each theme will have input. So someone needs to look at each week from the pharmacotherapy point of view. Someone needs to look at each week to see from the surgical point of view. So that when each week is developed, all of these themes will have had an ability to layer on their information that they think is useful in that week.
Is the dental school still
Yeah. First 2 years, correct.
So will be dental input into
We haven't talked about that. We haven't. That's the first I've thought of that. We haven't. The last theme that I felt interesting was looking at diverse populations and equity. And Dr. Goldenberg and I, for quite some time, pushed to have under a theme men's health, and we were trying to parallel this with the women's health, but we were unsuccessful in getting this included as a theme, so that we'll need to be more focused on our infiltration into the curriculum. We won't automatically have a lens that looks at men's and women's health. But we do have first people's, addictions, geriatrics, and palliative that will have input into each week. Putting together the course structure, so the medical school still remains 4 years. The first 2 years mainly didactic, the third and fourth year mainly clinically based. And they've broken it up into these courses, Med 411, 412, so the 4 is just medicine, 1 being first year, 1 being first half of the year. So if you see this terminology when someone asks you to present in 422, it's medicine, second year, second term. And they've given a theme to each of these blocks, being the first year being foundations of medical practice, and then going on to flexible enhanced learning later on, and so on and so forth. The first 2 years are still didactic, and so that's where we are right now, is looking at course development. And so they've come out with a case-based series. I know this is difficult to see, but this is the first 2 years mapped. So this is the first 2 years blueprinted into what is going to be the theme of the week. And so if we look at early on, it's fetal development, allergic anaphylaxis. I find it interesting that you jump right into breast mass, but sort of all of these things are the basics of abdominal electrolyte, cardiology, function, and absorption. So you go from more of the basic physiology to later on becoming more involved cases, hypotension and shock. So you go early on to a defined, focused theme to more integrative as you go along. And if we look along the way with each of those themes, they've assigned systems. One is a primary, so this is going to be your primary focus of the week, and then secondary systems that get to add information, and then the themes and clusters will layer on top of that. So in essence, the primary is in charge, the secondary is vice president, and then the rest get to layer on. And if you look at primary systems that we've been assigned, the only primary system week that we've been assigned now, they have stated the goals to be prostate cancer, BPH, and GU tumors. And so this was approved by Senate. This did not have input from the systems. This was done very early on and dictated on. This is the themes that they feel important. We do have weeks that I have pushed for us to be secondary system. So infertility has a week that traditionally has been run by gynecology and had a mention of male fertility, as well as adrenal dysfunction. But when looking at the curriculum, if we just have BPH, prostate cancer, GU tumors, adrenal dysfunction, and infertility, which makes sense to be urology involvement, we miss out on things like voiding function, urinary infection, continence issues. And so I've pushed for us to be secondary system on spinal cord injury and multiple sclerosis, because voiding dysfunction, erectile dysfunction would to me seem logical to discuss in those weeks. And then in sepsis to talk about urinary obstruction, urinary infections, to be the root of the case be urosepsis, and then have a little bit of input there.
Would it make some sense to include pediatric urology in that congenital dysmorphism?
Mm-hmm. That's a good idea. Which week is that? The 39. Okay, great. As I was going through this, one of the orphans is pediatric urology, and it's for the last. Yeah. The trouble is that's so early on that it's such basic physiology at that point. They're talking about mitosis and meiosis, and they're not going to make time for systems to come into play there. But later on in the second year, I think that's a good idea. That's something that we should look at.
Did keystones make their way into any of the interactions?
Yeah, so sepsis, I think, is where we can put it, and as well in what's CKD. So there is electrolyte disturbance. There's acute kidney injury, I just highlighted the urology specific one. So Sunny is doing the nephrology, quote unquote, specific. So she's involved in a hypertension, acute kidney injury, electrolyte disturbance. What else is she involved in?
48.
Yes, CKD. Yeah.
So transplant will go in there?
Transplant will go in there. Yeah. it's interesting that our week is the first time that cancer will be discussed in the entire curriculum. So,
Breast lump.
well, yeah, that's true. That's true.
Why is it called a lump instead of?
So this is Dr. Masterson. I think you have a good idea there of infiltration of the pediatrics. So if we compare this to our previous exposure, in essence, urology had two weeks of the curriculum, 2 weeks in the block system. We had a week on hematuria and renal calculi and a week on urinary obstruction and prostate health. So I think that our exposure, we're down to 1 week, but being able to infiltrate as secondary systems, I think actually our exposure is going to be increased. Before, we didn't have much exposure on infertility. We didn't have exposure on erectile dysfunction, and certainly pediatrics hasn't been focused except in third year. At the end of the day, students, there's such a massive information. Everybody has all these goals. It would be ideal if we could teach everything we need to know, but the students have such an amount of information they need to know, really, what is important for them. So I took a look at the LMCC objectives, and at the end of the day, that's the medical school is interested in that. We may look at, so I mapped all of the objectives that I thought could maybe be urology, and it came down to these, that in the LMCC, they look at blood in the urine, erectile dysfunction, continence in both peds and adults, infertility, the scrotal mass, urinary tract injuries, urinary infection, and urinary obstruction. Interesting. So GU tumors did get mentioned just in the subcontext of urinary tract obstruction. And I think if we look at the way we've outlined the primary and secondary systems, that we do a decent job of these, and I found difficulties in where are we going to get pediatrics in the first 2 years. We haven't discussed the scrotal mass or urinary injuries, and that's where we got to remember there are 4 years of curriculum. The third year still delivers lectures, and currently that's the third year is where we plan to deliver more clinically based topics like the scrotal mass and urinary trauma. So the medical school has dictated templates for education delivery based upon this 70% FaceTime, 30% learning, self-based learning. And it is, for the first year, it's the same sort of structure as PBL was. 3 times a week the students meet in a case-based learning session. There's limited lecture time, which is orange, and then there's self-learning. Clinical applications is things like clinical skills, DPAS, and then there's histology and anatomy. And in second year, they've decreased the exposure to case-based learning. So this is where we focus. This is where our week is. Week 64 is in the second year. So as you can see, there's limited lecture time and still less case-based learning. And there's a lot of focus on these clinical applications, which would be family practice, clinical skills, DPAS. So when I looked at week 64, there's a vast amount of information that we want to portray in this week, and I thought that probably these would make sense. Talking about normal and dysfunctional voiding, this will be addressed earlier in the curriculum in the spinal cord week, so we'll be able to spiral back to that and reinforce that. We can look at lower urinary tract symptoms and urinary obstruction. We can spiral back briefly to hematuria. Hematuria is going to be talked about in the acute kidney injury week earlier in the curriculum. But then we can discuss some population health with screening tests using PSA as an example, and then finally having a discussion about PSA utilization in prostate cancer. So the example that I had thought was having a 60-year-old gentleman presenting to his GP with questions about his prostate health and allowing it to spiral from there, talking about bothersome urinary tract symptoms, where the students will discuss normal and dysfunctional voiding, discussing this the concerns about a diagnosis of prostate cancer to begin the discussion about the utilization of PSA screening. And I thought it would be useful after that to go on to a diagnosis of cancer. So early on lower urinary tract symptoms, possibly, the urine dip is positive for hematuria, to spiral back on that, and then go on to the discussion of screening, and then finish off with a conclusion about prostate cancer treatment and how to counsel people about a newly diagnosed malignancy. So I think that the screening test and the disclosure of a newly diagnosed malignancy would be skills that are transferable outside of just urology, quote unquote. So spiraling in there is the normal micturition, which we've previously presented in first year in hematuria. And as I sort of formulate this in my head now, with the limited lectures we have, what I had proposed and would like feedback on is how best to deliver these lectures and what the topics of greatest impact for the students would be. And I think that to revisit normal and dysfunctional voiding and lower urinary tract symptoms would be very important for the greater than 50% of the students will use that on a daily basis if they go into family practice. I thought a discussion of screening tests, sensitivity, specificity, population health aspects of that, and gynecology has asked if they can be involved in that as well, utilizing things like breast screening, pap smear, PSA as examples of screening tests, and then going on to a discussion of prostate cancer, and then having a discussion before that of hematuria, urothelial malignancy, so following the progression of the case, and then finishing up with imaging of the urinary tract, and then just a wrap-up of the week. Yes?
To that point, to actually broaden the second topic, instead of clinical assessment and management of urinary tract obstructions, say clinical assessment and management of lower urinary tract symptoms.
Sure. Yeah.
So non-obstructive causes of
Yeah. Yeah, that's so. Are you wondering about talking about incontinence as well, and overactive bladder?
as they come into the
That's a good point. That I think that would be valuable. It's a lot of information to cover in a 1 hour session.
I just wanted to Mark's point on for those case-based learning, that proposed case you mentioned, sure you need a content expert to run that section. I mean, just looking at values on the bleeding symptoms, I was wondering, can a PhD in microbiology run that session? I kind of doubt it. But feasibility of that is. I know, but it's and then you get uneven exposure. I mean, teaching experience to the students.
And that's in the past. That's why I've felt the case wrap up to be quite valuable as well, in that you unify questions that students may have at the end. And
do we have input into who is teaching these sessions?
No.
They just come from a pool of
people
who donate their time.
Well, they're paid.
Yeah, but that's what I mean.
But a lot of them are foreign physicians without positions here, or physiology, or anatomists, or other academic faculty.
So somebody who doesn't know the nuances of PSA screening is giving that?
Well, they're facilitating the discussion that the students have. So each tutor gets a defined outline of the learning objectives and the points that students are supposed to cover. So there is a booklet that they go through, and there's leading questions as they go through.
Who generates that? You?
Well,
Yeah,
we do.
Yeah.
Yeah.
I mean, that was a chronic problem PPL system too,
Exactly. And so it is challenging, and I think that's where having a quality student or tutor guide laying out exactly clear learning objectives and clear points that we want to get across is important.
So there was it 288 students per year now? Is that
Correct.
the number?
Yeah.
So you assume 10, there are going to be 28 sessions running simultaneously in this week.
Correct.
Where you can find 28 content experts.
The other interesting thing is they've got this clinical reasoning idea, which I'm honestly I don't understand at this time point. Is that there will be small groups of students that break away and take a topic, and with a content expert discuss it, and that hasn't been fleshed out yet because in year one this isn't included. This infiltrates in year two, and we're early on in year two. So I do have meetings coming up discussing this clinical reasoning, and I think the idea is to have contact experts there discussing the.
Is there a place for residents in this process?
It's in terms of PBL, I think it would be difficult because of the time commitment of the 2 hours from 8 till 10 on Wednesday and Friday. There have been internal medicine residents in the past that have, but I only know of 2 or 3.
Week.
It's 1 week, correct?
1 week a year.
Yeah. But the PBL or the CBL tutors are assigned to the entire semester. So they do all the cases of the entire semester.
They have to be experts in everything.
Well, they have to be able to read a tutor guide. Yeah. This, the PBL does have its challenges for
Are
sure.
you aware of the similar challenges at other medical schools in Canada where they have a lack of content experts to provide undergraduate teaching?
Well,
Has it been discussed at all?
the ideal. So when you're dealing with a PBL session, it's so fluid that you just, as a tutor, you're there to simply allow the students to discuss the case in any manner that they wish possible. And some of the tutors took it upon themselves at the end to say, okay, I've got this tutor guide. You guys should have talked about BPH and voiding symptoms and PSA, but at the end of the week, the students can come to a completely different conclusion. And that was one of the criticisms of it. Case-based learning is very new. It's trying to unify all those tutors who said, like in PBL, there were a lot of tutors that said, look, no, this is what the tutor guide says you should learn. And so in essence, case-based learning is turning all the tutors into that tutor. I think the content experts and the importance of the didactic lectures, that's why I see the importance of not just delivering completely separate information in the case from the lectures that you deliver. So if you have a PSA discussion in your case, later on that day, Dr. Gleaver Allen's going to give a lecture on this is, I know you had this discussion, but this is really the point I want you to get from this. So we do have exposure to contact experts in our lecture. And I see that week wrap-up as very important because over the last few years of me being involved in FRGO, I've found that the Friday, allowing them to ask questions and unifying their sort of learning that they've done for the week, very important.
Thinking back to Hunter, because Hunter's been on the case-based learning center for a while now.
Mm-hmm.
We went through all that, and we'd always have these afternoon sessions of working through these problems. And I was trying to think back of who delivered them, and there was the core medical education people that would give things, and then they'd also try to infiltrate the residents and some of the staff. And it was the same for urology. I think it was mixed a little bit with nephro, and there was about a week of lectures and stuff. And either, there, because there's no residents, the staff would give it, but anesthesia, ortho, some of those residents I remember coming back and running some of the sessions, that it might be more informed than some
Mm-hmm.
others.
Mm-hmm. I think if we look at this clinical reasoning, I think that is going to be a valuable session as well because we will be asking for 20 or 30 faculty to be involved in those.
Is there any mechanism to pay fellows and residents if they happen to participate in this? Is there any
I don't know.
faculty paid
I don't know.
for the time?
Coming back, so a big part of acute and chronic kidney is obstructive.
Mm-hmm.
Is urology going to be part of that?
Yes. Yeah. So Sanit and I work together on those weeks. And you know, before in Fergu we had an entire week on obstruction that led to acute kidney injury, that led to an infection, and dealing with BPH and lower urinary tract symptoms. But now, down to 1 week, we've had to sort of piece that out and spiral it in. So that's just the first 2 years. We still have the third year of junior clerkship and the senior clerkship, and they've broken it down now. So instead of the quote-unquote big three, and then the two other blocks, they've broken it down into 4 blocks of 12 weeks each. And so we will be under operative medicine. So students will be on a rotation of anesthesia, surgery, and orthopedics, rotating through us.
Are there mandatory rotations in there, or is it all
Yeah.
electives on that?
Yeah. So they're still fleshing that out. It's still in progress of how exactly they're going to break it down. I don't know if it's going to be out of those 12 weeks. It may be 4 weeks of anesthesia, 2 weeks of ortho, and 6 weeks of surgery, being general surgery and urology, thoracics, and so we may go back to the 6 weeks. Currently, we're at an 8-week exposure to surgery with 4 weeks of a subspecialty and 4 weeks of general surgery. And so they've laid out the proposed cases to be delivered in third year, and under surgery, they've put scrotal mass and hematuria, and delivered in the obstetrics and gynecology, which is under children's and women's health. In that block, the students will talk about these in their seminar series. So urology infiltrates the surgery, the obs-gyn, and the emergency seminars. So we still have a lot of work to do. The outline's been laid out, but we still have to get some granularity. The content, both case development and assessment. And interestingly, they want the assessment. They want all the exam questions before we finish the content. So very soon we need to have to the assessment team our multiple choice questions and oral exam questions that we deem important as our exit competencies. Dr. McDougall has been fantastic in writing exam questions, editing our current ones, and going over our oral exam questions as well, and I'm very indebted to her. And last, before I finish up here, I just wanted to point out a resource that I think is extraordinarily important to point our students towards. Recently, the AUA has put out an iPad app and an online medical school curriculum, and it is amazing. They've done an amazing job. They have, in essence, gone through what the AUA membership feels is the important things for primary care physicians to know when they go into practice. And so in this one-page PDF, here's everything that you should know. In essence, what is your exit competency? So I think if our students look at this medical student curriculum on this app, they're going to be doing very well for both their LMCCs and their American boards. And so they have both the core content, and they have examples of uroradiology cases. They have interactive cases in urology. So every student that I see come through, I make them download this app and say, go through these while you're here.
Mr. Bond never has a rectum
That's a typo.
Mr. Powers.
Slides to adaptive devices.
Yeah. So this may be some, and it's an iPad app. They can just download it and put it on, and it's got, so as they're going through our right now clerkship, you can say, tonight go over the thing on BPH and let's talk about it tomorrow. And it's just an easy, compact way of delivering this education. So, and I think that if we were to link this to our undergraduate website, so I've talked to Dr. McDougall, who is very involved in that, of getting permission to link to that from our website as well, to get exposure. That was a lengthy discussion on sort of where we're at and where we're going. Most of the time you feel like you're the king of the world, but sometimes it seems like a bit of a sinking ship. And right now we're sort of clinging and trying to get things done. And I want to thank thus far Dr. McDougall, who's been instrumental in the assessment side of things. And I thank her for allowing me to rely on her expertise, and Dinesh, who has been involved in our lecture delivery in first year, putting together hematuria cases. And now I wanted to open it up to more discussion on where feedback, and we'll have a sign up form.
Thanks, Brian.